midlife health has to have a conversation about hormones because women are going to lose those hormones, the progesterone, estrogen, testosterone. The best way of predicting when you will go through menopause is ask when your mother went through menopause. 100 years ago, women really weren't living long enough on average to outlive their ovaries.
And then in terms of HRT, is it ever too late to start it?
Being on HRT within 10 years of menopause decreases your cardiovascular risk by 30%, decreases your risk of an osteoporotic fracture by 30% at least.
Do any of the negative conversations about HRT actually have any merit?
No.
Noor, welcome to the show.
Thank you for having me. I'm thrilled to be here.
I want to ask you about hormone health, what it means. Is it just taking extra things? Is it just looking at, lifestyle factors? How would you define it as like an entrance into hormone health?
So I think, first of all, we have to just define what we mean by hormones. I think the word hormones, actually, we have thousands of hormones in our body, right? So insulin is a hormone, growth hormone, thyroid hormone, parathyroid, calcitonin, I could go on and on and on. Leptin, ghrelin, we have thousands of hormones in our body, and all of them have really important work to do. And we're really, really sensitive to what they do in our body. And it's really how any signals are sent around our bloodstream to different parts of our body from another part of our body. And that's what a hormone is. A hormone is a chemical signal that's sent along in the bloodstream. So in the setting of the conversation, I think we're talking about, and there's a lot of people have deep feelings on what you call them. We're talking about what conventionally people would describe as sex hormones. And we have a problem with that word sex hormones because it pigeonholes those hormones into kind of, and all they do is reproduction, right? What we now know is those hormones, and by those sex hormones, I'm describing progesterone, estrogen, testosterone. We now know that those hormones affect every part of our body, right? So, do we call them progesterone, estrogen, testosterone? Do we call them neuroendocrine hormones? What do we call them? But I think that's kind of what you're describing when you ask the question about hormones and midlife. So the really important thing that I always like to get across to people is that midlife health has to have a conversation about hormones, especially in women, because women are going to lose those hormones, the progesterone, estrogen, testosterone to a lesser extent. So we are going to lose those hormones. There's nothing you can do in your lifestyle. There's no amount of weight that you're going to be able to lift or supplement that you're going to take or alcohol that you're going to avoid that's going to bring those hormones back. Yes, if we were talking about midlife health and your cardiovascular health and your muscle mass and your bone density, then lifestyle factors come into it. But there's no lifestyle modification that is going to bring back your ovarian function.
Mm-hmm. And as you say, it's literally something that women will all go through, and you can't avoid it. You can't out healthy lifestyle, or out green juice or whatever it is. All of this, these processes, the loss of these hormones and the manifestations that come with that, they are just part of life. But it's quite an interesting conversation because despite being one of the inevitable things that women will go through, there's not a huge conversation about it. It's really opened up in the last few years. And I want to know a little bit more about your journey into being such an expert of this, because I know that was something that you kind of thought yourself, like, gosh, okay, we're going through this, and then hold on, there's no conversation about it. Like, what is going on? Talk to me a little bit about your experience with that.
Yeah. Well, I'll tell you, I went to medical school in Dublin, Ireland, and I was in medical school in Dublin in 2002 when the WHI came out, that study that kind of like, wrecked the whole thing for everybody. And I remember that really well. And I remember just a complete pivot, like nobody takes hormones, don't take hormone therapy. We don't teach you about it. We don't talk about it. And then I did my training in general practice in the UK. I was trained by the Royal College of General Practitioners in the East of England Deanery. And same, we just didn't talk about hormones, or we didn't talk about menopause. It was kind of like, oh, well, that's a heart sink patient. We described them as heart sink patients, the women that would come in over and over again with their migraines or their joint pain or their inability to sleep. And it was like, oh, well, that's a heart sink patient, because like what else I've offered them, I can't help them. Nothing else,
What do you mean by heart sink? What do you mean by that?
Sink. because they were
Oh,
on your
okay.
schedule, because you would be like, I don't know what else to offer this person, which is such a sad thing to say. I mean, what else were you going to do?
Yeah.
And, so I just didn't know about menopause. I very little. I knew hot flashes and you stopped having your period, but that was pretty much all I knew. And then, and when I was 38, I started to have what I would describe now as perimenopausal symptoms. But at the time, I thought I was having psychiatric symptoms. I thought I was burnt out. I was having intrusive thoughts. I couldn't sleep. I have severe anxiety. And I, was in the neurologist's office and in the psychiatrist's office and trying to get help. And they were trying to help me. Nobody ever said the words, could this be perimenopause? What's going on with your period? Nobody at any point in all of that experience. And then I remember it was the middle of the night and I had what I now know was a night sweat. And it just like clicked in my brain, like, oh my goodness, I think this is menopause. And I remember starting to ask for help from a menopause perspective. And they were like, you're too young. What are you talking about? You're 38, you're 39. And I persevered because I had then gone down the rabbit hole of reading everything I could find, getting on every WhatsApp group I could find, going to the meetings, and suddenly realized this whole world had opened to me that I didn't even know existed. I knew nothing about. And once I did get on hormones, thankfully somebody took pity on me. It was an overnight, 48 hours, and my psychiatric symptoms were gone. And I
It's
thought,
quite.
I need to bring this to some other people. I need to bring this care to others because they can't access it.
So talk to me about like the mental side of symptoms that you had, because again, you say the word perimenopause, and I think a lot of people would think of what you gave the example of, the hot flushes, your period maybe becomes less regular and then you lose your period. Um, but the whole like intrusive thoughts, anxiety, that is something that is quite surprising, really, that it's linked so severely as well, to the extent that you were suffering from it.
Our brain runs on estrogen. It's the female brain runs on estrogen. And once you understand when there is not estrogen around, your brain goes into like a starvation. But really, now that I've done this work and I see women all the time and I've, probably seen, I don't know, thousands of women. And I would say in perimenopause, psychiatric symptoms, I think are often the first things that appear. Anxiety, panic, inability to sleep, feeling, intrusive thoughts, like all of a sudden I'm really, really anxious about stuff that I was never anxious about. And then the hot flushes come later, the night sweats come later, the changes in weight come later, the joint pain comes later. It's those psychiatric changes that I think are the earliest manifestation of perimenopause. And what happens is that women are like, oh, well, it's because you've got little kids, or you're going through a divorce, or you've got a lot of stress. It happens at an inflection point in a lot of women's lives when perhaps their stress level is high. Yeah. They've got lots of changes happening in their life. And so everybody just blames it on that. Themselves blame it on that. It kind of gets lost in translation. And that's how they end up on psychiatric medications. And oftentimes by the time people make it to me, they're on psychiatric medication and they're not better. And then we're struggling to get them off it.
And there's so many things that it's linked to as well. If you're not sleeping, your anxiety level is going to be higher. If you're feeling anxious, then your stress levels are also going to be higher. If you're having intrusive thoughts, you're going to feel a lot more anxious, and then you're going to be more stressed, and then you can't sleep because of all of these things. And it
Yeah.
is that cycle of effect
Mm-hmm.
that then there's all of these unanswered questions, because you're going, well, where is all of this coming from that I'm actually trying to deal with? And you said, lifestyle factors, that many women, at that point in their lives, do you have a lot of high stress environments that they're in, no matter what the situation is. And it's a lot of different things to deal with all at the same time, especially under this big question mark of what actually is causing it, because this narrative of perimenopause is more open now, but it's still, it's hard to work it out. It's hard to have that conversation and figure it out in your mind of, hold on, this is normal.
Yeah. And my husband always used to say to me, my husband's older than me. And when I was really struggling at night and having such terrible anxiety, he used to always say, it's always darkest before dawn. You have to remember it's always darkest before dawn. And, and that's true. If you're awake at 3 o'clock in the morning, things look bad in your life. If you're awake and can't sleep and you're anxious, things look terrible. It's really a scary time of night to be awake and struggling with your anxiety by yourself, in the dark. And you're right. It becomes, you're in this kind of cycle then where you're afraid to go to bed because you're afraid you're going to wake up. Then you haven't slept. And, it just, the whole situation gets worse and worse. And I think one of the difficulties people have with perimenopause is that it's not measurable. So people love things to be measurable, or, it's something defined. Like, menopause is defined as a point in time at which you're a year without a period, which is a terrible definition that we can talk about if you want, but it's defined. So people have, oh yeah, no, I haven't not had a period for a year, so I'm not in menopause. Or are you diabetic? Is your A1C greater than 6.4? Then you're diabetic. People love things to be and in medicine, we like a definition. We like it to be measurable. We like clinical criteria. It all has to be very, right angles and straight lines. And perimenopause is not right angles and straight lines. There is no diagnostic criteria really for perimenopause. There's nothing you can measure in blood work that's going to tell you you're in perimenopause. Perimenopause is just a clinical diagnosis that involves listening to what your patient is saying to you and thinking, okay, this sounds like perimenopause. And at the end of the day, sometimes the diagnosis is in the treatment. And I say this to people, well, why don't we try an estrogen patch? And if you feel better, then that's your answer. Sometimes the answer is in the treatment. But it's the difficulty with perimenopause is this lack of very, very firm, measurable definition criteria that people really struggle with.
Yeah, because even defining perimenopause, how would you actually give that a definition in itself? It's quite a tricky one because it's the pre-stage, but
It is
it's a hard one.
exactly. I mean, to define perimenopause, we need a new definition of menopause. Because once you redefine menopause correctly, then perimenopause comes into view behind it. So I like to, currently menopause is defined as a point in time at which you're a year without a period. Now that's a terrible definition. It does not serve women. It makes it about periods, which is a symptom. What about all the women that don't have periods? Like they have an IUD or they've had a hysterectomy or they've had an ablation. Additionally, it draws a line in the sand. Like if you're past this point, suddenly you're fine and you're home free, which you're not. And also ignores the entirety of the symptomatic menopausal woman who starts long before her last period, those symptoms start. So you're just ignoring her entire lived experience and saying that it's about this one day. So I like to redefine menopause in the setting when we're talking about it here in my clinic as the point in time at which we run out of eggs. So menopause is when we run completely out of eggs and we have no eggs or follicles to develop and ovulate. Perimenopause is when we reach a critical threshold and we're running out of eggs. And once you start to talk about what a normal menstrual cycle is, and you start to say, okay, in a normal menstrual cycle, you're going to put out over 100 follicles. You're going to make 100 follicles to get that one egg out in a normal 25-year-old menstruating female. But in perimenopause, you're running out. So maybe you have 6, maybe you have 10. And when you start to understand that, you're like, okay, that makes sense. So if I have less follicles, then I'm making less hormone. And then maybe I don't ovulate. So maybe I don't make progesterone. And the whole thing becomes clear. So redefining menopause helps you to then lay down a definition of perimenopause.
And you mentioned you were 38, 39 and almost no, you're far too young. You can be having these symptoms. It couldn't be the perimenopause. But what is the age that people can have does it vary? Like what makes it vary? Are there any rhythms or patterns, or is it all quite random?
So the best way of kind of predicting when you will go through menopause is to ask when your mother went through menopause. So there is a genetic, link there. You're more likely to go through menopause around the time that your mother went through menopause. But when you think about when you could go into perimenopause, in the US, the average age of menopause is between age 51 and 52. And perimenopause can start 15 years before that. We know
Wow.
that normal menopause can be anywhere between 45 and 55, with the average age at 51, 52. So if you go through menopause at 45, you could have started your perimenopausal symptoms when you were 30.
That's pretty wild. Oh my goodness, you could have
Very big
15
window.
years. Yeah, you could have 15 years of the symptoms. And then we're gonna go, like, let's go for it. What do? We have these symptoms. We come to you and we say, like, Noor, help me. I'm feeling all of these things. I think it might be perimenopause. Maybe we've got to that, that point of we're sort of identifying it. What's your advice? What do you start? Because I imagine also it's not as simple as just, smacking a prescription down. These women will be vulnerable. They will be upset. They will be burnt out of trying to find out what it is. By the time, you alluded to, a lot of people come to you after they've tried everything else. They could even be very heavily on another medication. What do you do? What do you say?
So when we have I spend an hour for my first visit, really to kind of dissect the whole story. What is the history? When did it start? What are the symptoms? What have you tried? What is your medical history? Tell me about your pregnancies. When was your first period? What was that like? We want to know everything, right? We want to really, really paint a clear picture of what happened before now. So taking a really great history and allowing the patient to tell me their story is fundamental to the beginning of our relationship. And I ask people a very open-ended question. Tell me why you're here. Tell me everything. And people will tell me everything generally. If I'm quiet and I let them speak, they will tell me the whole story in their own words. And it's important that I listen to that. Now, if a patient presents and she's perimenopausal and I think her symptoms are perimenopausal, I will start her on treatment that day. We will get her going on some treatment that day because she's looking for relief and we need to give her relief. But in the background, I do a lot of workup. We have a DEXA scanner here, so we get an idea of bone density and body composition. What other concerns, because a lot of these women, especially if they've been perimenopausal or menopausal for a long time, their bones aren't great, right? So they've got osteopenia or osteoporosis, and that's a conversation we need to have. And
So
then
they
we
could
do a
actually
full.
have osteoporosis. Could it be an early stage? Because when you say osteoporosis, you kind of think of someone who's very elderly and frail. But actually, is there different levels almost to that it can develop for a long time?
Oh yeah, I mean, I've put 30-year-olds in my scanner and they have osteoporosis.
Really?
That's why I bought
Um,
my own scanner because I wasn't going to rely on anybody else scanning them. It's terrifying. But unfortunately in the US, we don't, everything is with insurance, and insurance won't cover a bone density scan as a screening test for a woman until she's between 60 and 65. And oftentimes it's too late. Like, prevention is the name of the game. If we want to prevent these midlife diseases like cardiovascular disease, like dementia, like type 2 diabetes, sarcopenia, which is loss of muscle mass, like osteoporosis, we need to be picking that up in their 30s and their 40s at the latest so that we can offer intervention that's going to stop any progression and maybe improve things overall.
wow. Sorry, I interrupted you while you were you were on a roll.
So we do a DEXA scan, then I do a full set of labs. The other reason I do a full set of labs is because we need to make sure that nothing else is causing your symptoms, right? So if you're super fatigued, what's your ferritin? What's your iron? Are you anemic? What's your B12? You're gaining weight uncontrollably or you're peeing all the time. Are you diabetic? What's your blood sugar? We need to make sure that we look at everything so that we can address everything, because it's not uncommon that there are two or three things happening at the same time. It's not uncommon that I have a woman come in and she has perimenopausal symptoms, but oh, oops, okay, we just diagnosed diabetes and osteoporosis, right? And we need to kind of co-manage all of those things at the same time.
And then HRT, it's an interesting one because there's quite a lot of different opinions on it. Obviously, you're very pro it. Some people maybe think, oh, actually, I don't want to go on anything additional. I'd rather keep things, a bit more natural. And then, of course, there's the discussion of, well, it causes X, Y, Z. It causes different types of cancer. It's really bad for you. Like, there's loads of different side effects. Can you tell me medically from your experience what your views are on HRT, what it is? How do you take it? How does it perform?
So HRT is kind of like people keep trying to rebrand this word. So when you say HRT, you mean hormone replacement therapy. So people try to rebrand it. They call it hormone therapy. They call it menopausal hormone therapy. They've called it progesterone, estrogen, testosterone. They've called it hormone optimization. There's a lot of discontent with the naming of the thing. But if basically HRT is progesterone, estrogen, and testosterone in some combination. So it could be progesterone alone. It could be testosterone alone. It could be estrogen alone. It could be all of them. It could be only progesterone and testosterone. It could be only estrogen and progesterone. There are many, many hundreds of different ways that you can combine these hormones and still call it HRT. So it's important that when we say HRT, we're encompassing really replacing progesterone, estrogen, testosterone in some combination or even alone.
And
And
what do
what you
they do individually? Sorry, but progesterone, estrogen, and testosterone, what do each of them do as individuals?
Let's talk about it. So progesterone is what I call our stress management hormone. It's the hormone that keeps us calm. It manages our anger, our irritability. It helps us to sleep. It keeps our blood pressure down. There's like a relaxation effect that progesterone has on our body. Estrogen, on the other hand, you have an estrogen receptor on every cell in your body, right? Every cell in your body has an estrogen receptor. So your eyes, your ears, your lungs, your heart, your mouth, your hair follicles, your skin, your heart, your gut, your pancreas, your liver, your muscle, you have an estrogen receptor on every cell in your body. Therefore, loss of estrogen is not hot flashes and night sweats. It's a multi-system problem. And I have women that come in and see me, and their main symptom is burning mouth syndrome, vertigo, chest pain, rashes, tinnitus, GI symptoms. It can be anything. And that's very individual how somebody presents. But in terms of functions in the body, estrogen has a function really in every tissue in the body and is involved in the function of every tissue in the body. So loss of estrogen is going to affect every tissue in the body. Testosterone has very similar effects to estradiol. So the way that I like to explain the function of testosterone is to understand a man with metastatic prostate cancer. Let's call him Joe. Joe is 62 years old. He has metastatic prostate cancer, and they want to treat him by suppressing his testosterone with a medication called Lupron. He's 62. His circulating total estradiol level is probably about 300. Just to give you something to compare to, mine before I started treatment was 14. Okay, so his is 300. When he was 25, it was probably 900. So there's an overall decrease in men and women in the amount of circulating testosterone. So his testosterone currently is 300. Then they give him this drug. They suppress his testosterone, and now his testosterone is less than 0.01. It's undetectable. He comes in here and he has hot flashes and night sweats and insomnia and mood disturbance and weight gain and osteopenia. And so loss of testosterone is menopause, right? And the reason I'm telling you this, I want you to understand that estrogen and testosterone have very similar effects on the body. They're very, very similar in effect. It's just that testosterone at higher levels is more androgenizing, so has more of a male effect on the body, and that estrogen is feminizing. So there are menopause specialists out there that have a very testosterone first approach to their treatment. So they'll take a menopausal woman and start her only on testosterone. And they can often control a lot of her symptoms with testosterone alone. The problem with that is that you have to escalate the dose to get that control. And the higher you go on the dose and the higher her circulating testosterone levels are, the more likely she's going to maybe develop some androgenic symptoms, right? So losing hair where she wants it, growing hair where she doesn't want it, changes in her voice, more oily, acne prone skin. So there's a balance to be struck between the two things. But testosterone is a very important component of hormone therapy because it's a really important hormone in women's bodies.
And what's your magic potion? What's your balance of the three?
So that grows so much from individual to individual. You're not going to, people always ask me that question. Well, what's such and such on? It doesn't really matter what such and such is on because you're different. So there is like a finesse and there is a magic potion, like you said, that you're going to find kind of the balance for each person. But my general approach is to start with an estradiol and progesterone. And I use estradiol generally in a transdermal form, so through the skin. So that's going to be like a patch, a gel, or a spray. So I'll do estradiol at likely starting at a lowish dose and then escalating. And I'll start an oral micronized progesterone, which is a capsule that I give that you take at bedtime. Then we kind of go from there. Some people don't tolerate progesterone, so you pivot. Some people don't feel it all, so you increase the dose. Some people hate the patch, so you switch to the cream. And you just kind of like play with the doses until you get relatively good control of symptoms. And then in the meantime, we've done some lab work. We've done a DEXA scan. We kind of know where our baseline is. And often, depending on the symptomology, I will back in with some testosterone.
And you mentioned when you were talking about your own experience, you started this hormone therapy and overnight you suddenly felt the difference. What sort of difference are we talking about? Like, what do people generally experience?
So it depends on their symptoms. For me, it was an immediate improvement in my psychiatric health. Immediate. I could sleep, and the terrible, debilitating anxiety, intrusive thoughts were gone. It was
Which is kind of
immediate.
crazy because when you think about mental things, like things that are going on in your brain, you don't think quick fix. You almost
Mhm.
think, oh, okay, my back doesn't hurt anymore. That's fantastic. But,
Yeah,
your anxiety decreasing is actually quite a wild thing to get your head around. So that's really cool.
yeah, instant. And then it's somebody is hot flashes, for example, is their most debilitating concern. Usually we can get hot flashes under control pretty quickly. Brain fog, maybe a little bit longer. Joint pain, maybe a little bit longer. It really varies from one person to the next. Some people you'll see significant improvement almost immediately. And then for others, it takes a couple of months before you're getting kind of maximum benefit. And that's, again, just an individual thing. And it probably has something to do with the way they metabolize the drug, the way they are built kind of from a physiological perspective.
And why are some people really unsure about using it? Why do you ever have any resistance of people saying, no, 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 I don't want to do that?
So the resistance really comes from 2 points. The first one is the misinterpretation of studies that suggested that taking hormone therapy or estrogen increased breast cancer risk. So that's one reason, which has been disproven, and we can talk about that if we want to, if you'd like to. The other reason is this belief that natural is better. And that's a really tough one for people to get their head around. And when people say to me, but it's natural, and I say, yeah, it's natural for you to get osteoporosis. It's natural for you to get sarcopenia or type 2 diabetes or cardiovascular disease or dementia. And if you wanted to take that chance and do what's natural, you could, or you could intervene. You could say that 100 years ago, women really weren't living long enough on average to outlive their ovaries. So right now we're saying our ovaries kind of pack up and are done around age 52. If you go back in time 100 years, women weren't really living past the age of 50 to 55. Like this, the women living an additional 30 years has really only happened in the last 100 years because of a combination of antibiotics, vaccines, better nutrition, and better sanitation, right? So we're all living longer suddenly. So we've added 30 years to our life expectancy. But now we have 30 years of not having any ovarian function, which wasn't a thing before, right? So we could say, yeah, that's natural, but it's just not even natural for us to live this long, to live till we're 80 and without our hormones. So you could take the view that, well, nothing about this is natural. So I want to make sure that I live to 80 and I'm vital and I can walk and I'm independent and I'm strong. Or you can take the view of I'm going to toss it up and just see what happens and hope for the best for my biology.
I was going to ask you about that. How has it changed and how are women, because, now in modern society, we're inside a lot more, we're eating a lot more processed foods, we're exposed to a lot more toxins and microplastics and so on. Obviously, technology is a whole thing. But then it's quite an interesting point that actually, if we take the span of 100 years, even like, gosh, if we went 200 years, it's actually quite a newfound situation that we're all in. So even if we zoom in a little bit on your work alone, and you've worked with over 1,000 women, are there any developments in terms of like people who are inside more, or who are less active, or who are less healthy? Are there any patterns that you can see, or is it really just kind of quite sporadic?
In terms of hormones and
In terms of the
symptoms.
severity of things, yeah.
So I would say yes and no. I mean, I would say we know that, for example, if you live a healthy lifestyle and exercise, that will generally help your sleep. Maybe you'll have a little bit less hot flashes, but part of us wonders, is that just what you're just coping better? So you're not reporting as much, right? And so there's all these confounding factors that would say, is it that the symptoms are not as bad, or is it that you're reporting them less because you feel less bad because you're doing all these other things? It's important to take into account and say out loud that lifestyle is very important. We need to be doing all the things and exercising and eating well and getting outside and, avoiding toxins and not smoking and not drinking. But that's not going to resolve your hormone symptoms.
Yeah,
Yes, it's
because
great.
going back
It's going
to
to,
back
go
to
ahead.
the start, we all go through it. It's something that we can't avoid. And another
Mhm.
thing we all go through is the menstrual cycle, the period cycle that say 28 days on average that we go through. So then you've got a woman who's going through perimenopause and has all of these symptoms as well every day, let's say. And then she's going through this 4-week cycle where some weeks are great, some weeks are less great. How does that work in conjunction? Is it just a really big pile up of a disaster? Or because it sounds it when you have all of these things and then you add in, gosh, like I'm really feeling terrible, my period's due or whatever it is. How does that kind of manifest itself?
So to kind of understand that, we need to kind of lay down what a normal menstrual cycle is, right? So a
Please
normal
do,
menstrual
please do.
cycle. So to understand a normal menstrual cycle, let's imagine we pulled off the street a 25-year-old and we dissected her biology. So the first thing we'd understand is that her whole hormone orchestra is under the control of her brain, right? Two areas in the brain called the pituitary and the hypothalamus are like the conductors of the orchestra of our hormones, right? Day one of her cycle, her pituitary in her brain wakes up and says, let's make a baby, and starts to release follicle stimulating hormone, FSH. FSH comes down to the ovary, wakes up the ovary and says, let's make a baby. And the ovaries respond by stimulating follicles. So all these follicles start to develop. Hundreds of follicles start to develop. A follicle is a tiny, tiny cyst with a developing egg in the middle of it. Those follicles make estrogen. Estrogen's job is to prepare the uterine lining for pregnancy, make a nice cozy home for an embryo to implant in the setting of reproduction, right? So this is what we call the follicular phase. You're making lots of estrogen, all of the follicles are developing, your lining is getting thick, things are great. Come to the middle of the cycle, in your ovary, one of those eggs has won the race and become what we describe as the dominant follicle. Our pituitary in our brain knows that it's time, that one's ready and it's time to ovulate. So now it releases a burst, pulsed release of a hormone called luteinizing hormone, or LH. If you've ever peed on the stick to get pregnant, that's what you're looking for in your urine, this luteinizing hormone. Luteinizing hormone comes down to this dominant follicle and it triggers it to rupture. So the follicle opens and sends the egg on its way. And then we're left in our ovary with this leftover follicle that I always describe to people. It kind of looks like a deflated balloon, right? Just like sent its egg on its way and now it's kind of like deflated. That now is called the corpus luteum. And the corpus luteum is a really important job and it makes progesterone. And progesterone's job is to hold the uterine lining waiting for a pregnancy, right? They get a hold, if you've ever known anybody that's done IVF, after they do an embryo transfer, they give them high doses of progesterone. Why? Because we want to hold that lining in place and not have a period, because we're going to lose everything we put in there if we had a period. So we're making progesterone. Our brain is listening for any embryo hormones, right? Do we have a fertilized embryo? Is it making any hormone? And our brains are listening. Our pituitary and our hypothalamus are listening. We come to day 5, 6, 7, 8. There's no baby hormones. So it says, nope, there's no embryo hormones. So we must not be pregnant. Start again. So it drops our hormones. So our progesterone level drops and we shed the lining and the whole thing starts again. So that's a normal menstrual cycle, a very predictable rise and fall of estrogen progesterone. What happens in perimenopause, like I said, is you're running out of eggs. So now your pituitary wakes up and says, let's make a baby, and releases that follicle stimulating hormone. And your ovarian response is maybe 6 eggs. So 6 follicles start to develop. So not a lot of estrogen is being made, right? So your estrogen level is low. But in the meantime, your pituitary knows that you're not making enough estrogen. So it's pushing your ovary to try to find more. And what happens is it'll find more, 1 behind the door and 3 in a dark, dusty corner and 1 outside. And now we have a situation in our ovary where we have multiple follicles in various stages of development layered on top of each other. It's a whole big mess. Everything is out of sync. And what we see, therefore, is a rise in estrogen and a fall in estrogen. And a rise, we call that the zone of chaos. Then we come to the middle of the cycle and our pituitary is like, I guess we'll try to ovulate something. There's nothing to ovulate. It's a big old mess. So if there's no ovulation, there's no progesterone, right? So perimenopause is characterized by these very labile estradiol levels and very low progesterone levels. And in a setting of a menstrual cycle, it depends on how low your low is. Women are most symptomatic at their low. So early perimenopause, they're most symptomatic at that late phase, right? Because their valley is so low. But as things progress, it's low all the time. So they'll start with having symptoms right before their period. They're like, God, I'm so snappy. I'm angry. I'm irritable. My periods are heavy or they're longer. And then slowly that the length of time they feel unwell gets longer and longer. And then it's throughout the menstrual cycle because overall the hormone levels are low.
Wow. Okay, that makes a lot more sense. And then we move on to the menopause, which is when, your period stops as one of the symptoms, but not the best definition is what we know now. What actually then, like, manifestations are there in the menopause that we can look for? What's the difference between perimenopause and menopause?
So it's about eggs, right? So if you're not making any more eggs, then you're not going to have any periods. But if you're not making any more eggs, so if you don't make those follicles in your ovary, you're not going to make estrogen. And if you don't ovulate a follicle, you're not going to make progesterone. So you're going to make almost no estrogen and progesterone is being made, right? You're going for a very volatile, all over the place sort of picture in perimenopause to no hormone being made in menopause. And often we'll see, obviously, the period will stop, but all the symptoms worsen and become a little bit less labile. They're just there all the time. So the hot flashes are there all the time. The sleep disturbance is there all the time. Whereas previously, there might have been a little bit of a cyclical kind of nature to it.
So it actually just gets worse, really.
Pretty much. Mm-hmm.
Wow. Wow. Women have it rough, honestly. Like, the
Yeah.
more you learn, the more you think Guinness. And then in terms of HRT,
Mm-hmm.
when can people start it? Is it ever too late to start it? I know that's a question that people like to ask you.
We'll always ask that question. And for my personal opinion, it's not too late. The question about being too late is whether or not you can get benefit from a cardiovascular perspective. So we do know from studies that the earlier you start hormone therapy, and if you start hormone therapy within 10 years of menopause, you can decrease your risk of cardiovascular disease quite significantly. And that's where this idea of a 10-year window comes from. So if you start it within 10 years, you do have that protective benefit from a cardiovascular perspective. But if you start it later than 10 years, you might not have that same preventative benefit. That said, it's still going to have benefit for your genitourinary system. It's still going to have benefit for your bones, for your metabolic health, for your muscles, for your brain, right? So you can still have benefit past the 10 years, even if potentially you don't have the same cardiovascular benefit that you did if you'd started it earlier. From a question about how early you can start HRT, people also get themselves in a complete muddle about this. In my opinion, if you are old enough to take birth control, you're old enough to take HRT.
Hmm. And then with these symptoms, do they just go on and on forever until we die otherwise?
So that's very variable. There's some women that would say that their hot flashes last, 2, 3, 4, 5, 6, 7 years, and then they go away. People feel that their anxiety lasts for a certain number of years and then it goes away. And then you have women that are in their 70s and 80s who are still having very, very symptomatic. And so that varies greatly from individual to individual.
And when you have someone who's come to you and they're working with you, is it like a long-term thing that they're working with you? Like, are there stages that you kind of work through? Is there sort of that, maybe looking at lifestyle factors as well as, any medication that they might take? Or is it a case of you almost diagnose and fix their problem and they're off on their way? How does it kind of look in terms of like a long-term, I don't know if treatment plan is the right word because that kind of suggests that they're really unwell and it's actually just something that women go through. But you know what I mean in terms of like working with you, how does that look?
So again, that varies widely. One of the things that people come to see me for is their perimenopausal and menopausal symptoms, but then I'm looking under the hood, right? And I'm finding they're insulin resistant and they're this deficient and they're anemic and they've got high cholesterol or their muscle mass is really low or their bone density is not good. So often when we look under the hood, they might come to see me about hormones only, but I look under the hood and I find all this other stuff that we need to address. So it's important when I treat a patient, this is not a hormone mill. This is not what we do here. We're midlife health. We're about improving your health in every way that we can. Hormones are one of those conversations that we have to have. I do have women that come see me and they do like a 6-month package and we just get them kind of going and feeling better and then hand them off back to their primary care or their gynecologist, and that's fine. And then I have people that, there's a lot of things up in the air. We're watching their bone density and we're watching their cardiovascular risk, and it's more of a long-term conversation that we're having and a more long-term treatment approach.
And are there any common things that you do see when you look under the hood and you see all of these things? Are there commonalities of low bone density or cholesterol or anything? What are the sort
Yeah.
of
So high
trends?
cholesterol,
Yeah.
I would say the vast majority of perimenopausal and menopausal women have high cholesterol. I would say
And
a
what
lot.
causes that? Why? Because that's surprising that.
So it's a combination of things. It's a combination of genetics, but it's
Mhm.
also a combination of that change in metabolic health that's happening with our loss of hormones, right? So our metabolic health is changing. The way that we store fats is changing. We become insulin resistant, and that drives our cholesterol up, which is why women go from having a very, very low risk of cardiovascular disease in their premenopausal bodies to quite a high risk in their postmenopausal body. And that change happens really quickly. There's sort of an exponential increase around age 50, and it's because of hormones. And they've dubbed it the kind of metabolic syndrome of menopause, this metabolic change that happens in menopause. So I see high cholesterol. Very commonly, I'll see some insulin resistance, even in the setting of a normal blood sugar, which is why we just don't rely only on blood sugar levels to make a diagnosis. We also do insulin and C-peptide levels because we're trying to make sure, again, that I'm in the business of prevention rather than treatment, right? Because if you think about type 2 diabetes, if you have a diagnosis today of type 2 diabetes, that change happened in your body. That started to happen 12, 15 years ago. And if somebody had eyes on it 12, 15 years ago, they probably could have prevented your type 2 diabetes diagnosis now. And that's the goal, right? We're looking in more depth with a vision to prevent your chronic diseases from developing than not. But I would say high cholesterol and insulin resistance, very common.
And I want to zoom in a bit on bone density as well, because we touched on it a little bit earlier, but you've done quite a lot of work with people who have really suffered from osteoporosis as well. What causes this lack of bone density? Because we know that we lose bone density as we age, but can you give me a little bit of like the science behind that, and then what we can really do to help? Like, should we all be chugging milk cartons or doing lots of impact workouts, or what is the thought behind the experience that you have? What would you say?
So if you think about our bones are alive, right? Our bones are not inanimate objects. They're made up of cells and they're constantly turning themselves over. And we have grossly two different cells in our bones called osteoclasts and osteoblasts. Osteoclasts are always breaking down bone and osteoblasts are always building bone. And so there's this constant shift in architecture that's happening all the time throughout from the time you're born until you die. You have this change that's happening in your bones, and that's normal, right? There's many things that support their normal function, like our sex hormones, our estrogen and progesterone, but also things like our thyroid hormone and our procalcitonin and our calcitonin. All of them are involved in that kind of balance of breaking down and building that exists in our bones. What happens is when we lose estrogen and start to lose testosterone, one of those big supporters of bone building is lost. So we start to break down more than we're building. So you go from bone that looks like cheddar cheese to bone that looks like Swiss cheese because they're not balanced now. So we're breaking down more than we're building. And that the sad part is in this country, the majority of women's diagnosis of osteoporosis is going to come after a fracture
Mm.
instead of early diagnosis and treatment. The idea is when we think about hormones, the earlier you intervene with hormones, the more you will sustain normal bone density for longer, right? So early conversations around HRT, if you found, for example, or somebody that has a very strong family history of osteoporosis, I do, which is one of the reasons that I started HRT early when I learned what was happening in my body because I don't want to have osteoporosis and I have a very strong family history. So prevention of osteoporosis is one of the reasons that I take HRT. But other things that you can do in your body from your lifestyle, adequate nutrition, adequate vitamin D supplementation, regular exercise, weightlifting, lifting heavy objects off the floor. Why? Because one of the signals that your bone responds to is stress. So if I went out, send you outside and try go pick up that boulder, Emily, your bones are like, what is she doing? And respond. They're like, we gotta get stronger in case she tries to pick up the boulder again. Literally, you are giving signals to your bone to be like, you gotta get stronger because I'm gonna go pick up that boulder again. Lifting heavy things, jumping. So that downward force is really important to improve bone mass and bone density. Avoiding alcohol and avoiding smoking would be the big ones that I would say are going to change the outcome. So regular exercise, weightlifting, particularly jumping, adequate nutrition, vitamin D supplementation, avoidance of alcohol, and avoidance of smoking.
What does vitamin D do? What's the impact of
So
that?
vitamin D is very important for normal absorption and function of calcium in our body.
Interesting. Okay, so then that just basically all links together and then your bones get stronger. As we all know, calcium is good for our bones and it's not a myth.
Calcium is
And
very good for our bones because calcium, and it's not just calcium, magnesium and manganese and boron. There's a lot of essential other very, metals that are involved, elements that are involved in our bones, not just calcium. So if you're looking for calcium supplementation, try to look for one that does have those trace metals in them as well.
as we come to a bit of a close, I want to talk to you basically about your whole experience of this research that you've done, the women that you've worked with. What are some of the things that spring to mind as like the most surprising things in terms of just the narrative of women's health and fitness and then women as we age? What are some of the things that have just blown your mind?
Gosh, where do we even start? I think the biggest thing that has blown my mind is that I didn't know about the power of hormones to prevent disease. I just I didn't know. I don't know how I didn't know. I don't know how I wasn't taught. I don't understand how I wasn't taught that, being on HRT within 10 years of menopause decreases your cardiovascular risk by 30%. There are no drugs that do that. That, being HRT decreases your risk of an osteoporotic fracture by 30% at least. That there's potential for improvement in your mental health. I just didn't know all of these things. So it's just blown my mind that now I know, and now I feel like I have to tell everybody. And, one of the surprises, I suppose, that I've had is a lot of sometimes I feel like I'm in a vacuum, and where I work, it's a little bit more rural. And a lot of my, people around me, providers and doctors and practitioners, they just don't get it and they don't see it. And I just want to kind of scream sometimes because I'm so frustrated that women can't get the help that they want. Because sometimes they'll see me and then they'll, go and see their whatever for their routine follow up and they'll be shamed about taking HRT, which is just terrible.
Do any of the negatives or negative conversations about HRT actually have any merit?
No,
No.
they don't.
Isn't that
I mean,
wild?
if you have active breast cancer right now that's estrogen positive, you should not take, probably shouldn't take estrogen if we're trying to treat that. If you have endometrial cancer that's active, you should not take estrogen. Absolutely. Those are the two, I would say, scenarios that I would say that I would not treat a person with hormone therapy. And even in some circumstances, even in that situation, I might give her testosterone.
Yeah.
So I would
Amazing.
treat her. I just wouldn't give her estradiol. There's very few situations and scenarios where I wouldn't treat a person for their symptoms.
Wow. Noor, this has been really fascinating and so much to kind of dissect from that. And if people want to work with you, learn more about what you do, find out a bit more about the information that you put out online, where should they go?
So I'm mostly active on Instagram. Ask Dr. Noor is my Instagram handle. I'm very active there. I post a lot there and I repost a lot there. I practice in Exeter, New Hampshire, and I license in New Hampshire and Maine currently. I do see people from out of state and I do see international clients for second opinion consults and advice. And I'm happy to give that advice. So yeah, and you can go right to my website, which is lifestylesbynoor.com if you want to book an appointment.
Amazing. I'll link those below as well so people can check it out. And thank you so much for joining today, Noor. What a great conversation.
Thanks. Have a wonderful day.